Welcome to this video all about non-technical skills in cardiothoracic surgery and also now in cath labs. So my name's Joel Dunning and I'm joined by some fantastic people that are helping us to extend how we practice for emergencies, not just post-cardiac surgery but also now in the cath lab. So I'm joined by David Lazotte, who runs CSU ALS courses in cardiac surgery all across America. I'm joined by Leah, who's a clinical nurse manager here in Waikato, New Zealand, in cath labs. I'm joined by Madhav, who is a consultant cardiologist here as well, helping us to do practice for emergencies in cath labs. And Brian, who's not only a trainer in CSU ALS in New Zealand, but also helping us here to help with emergencies in cath labs. So it's all about teams practicing for these emergencies. So David, where are we at in America at the moment with practicing for arrests after cardiac surgery?
So it's a very exciting time in America right now. We have nearly 40 centers that have signed up for formal training, and we're talking to another 50 centers, so it's going to be a very busy year this year. We already have planned 100 courses, and I think we'll end up before the year is over being at 150 courses, so it's going to be a very busy year.
Yeah, that's fantastic, and we've actually already seen that the arrest rate is we've doubled the success, and really it is just following the STS guidelines that are now established. So the reason we're here in New Zealand is because we want to take this into cath labs. There are people doing TAVI and all sorts of other interventions, but we think there's a real need to get together as teams to practice those non-technical skills in the cath lab to work better. So Leah, what do you see as the main need for training as a team in a cath lab?
I think to work together. In our experience in the past, when there's an arrest, you'll have all sorts of people not being helpful, nothing really coordinated. So to enable us to coordinate something would be really helpful.
And does anything like that exist at the moment?
Not at the moment, no, not at all.
Yeah. And Madhav, I understand you had an emergency in the cath lab a little while ago. Just tell us a little bit about that and what happened.
I did. I had a perforation. A colleague of mine perforated vessel, and I came in, and we were in preparation for the REACT course, and I did apply some principles of the course, before the course actually happened, and it ran beautifully. There was a lot of calm, there was control, and we had a very good outcome in a very calm manner. So it's very obvious from my experience over the many years that there needs to be a course like this in the cath lab, and the standard ACLS rules do not apply in the cath lab. There's a notion that among our peers and colleagues that, oh, we know how to resusc, it's a standard thing, but cath lab is a completely different kettle of fish. There's a lot of things which needs to be incorporated, integrated, so that there's less chaos and there's clear communication amongst team to get a good outcome.
So Brian, what do you think are the main benefits of us practicing together in cath labs as a team? What can we do better in cath labs?
So I'm an anesthesiologist, and we're used to simulating, working as teams and communicating, and I think those three things are the most important things. Just learning to communicate, learning non-technical skills through simulation, and learning this REACT course in cath lab where these things are in its infancy is pretty cool to see.
Yeah, so it's anyway, we're halfway through our second day of a course, and it's been going really well. So we're going to show you a few videos about what we've been up to, and hopefully if you're interested, get in contact. We'll all try doing these courses all over the place.
So the first thing we did was we got together and we decided what were the key roles in a cardiac arrest. And we thought a really important thing was to free up the cardiologist and instead have an emergency leader that was somebody else. Secondly, we're going to have someone on airway and breathing. We're going to have someone on defibrillation and pacing. We need someone specifically allocated for CPR. A fifth person is going to be there for drugs, for timings and for vascular access. And then somebody else is there to call all the other teams together, to get the anaesthetist, to get the Lucas, to get echo, and also to command who's going to be coming in and out of the room. We've also got a full protocol, but before we talk about that, we thought we'd do some team exercises, and one of the most important thing is getting the Lucas on.
Set, go!
Get the Lucas. Go on, go on, Kieran. Hold the trolley, go, Kieran. Okay, I got the
As we were doing our practices, we discovered that it was in fact quite difficult to put a Lucas or automated compression device on, and it actually took multiple goes before we could do this in under 45 seconds. Thus, we thought it would be fun to actually do Lucas races and time how quickly we could get this on, and this halved the time and the efficacy of putting it on.
The React protocol. So we've talked about roles a lot, and I think that's because the roles and how we work together is almost more important than the exact protocol we follow, because working together is absolutely key. We need a Formula One team working fast to fix our patients, so that's our roles. But we need a really good protocol, and I think this isn't a really good protocol. I think it sucks. I think it's really good on the wards. I think it's really good out of hospital. I think it's fabulous, you know, if someone arrests in the lounge downstairs having their organic coffee. But it kind of sucks in our cath labs. We don't want to start the CPR. I want to shock a person in VF. If we've got asystole, I want to give them some. I want to put external pacing on. That's our priority. I think non-shockle and shockle is a bit basic for us. I think we've got VF for shocks, but we can use our pacing quickly and efficiently. And we've got pacing labs. We're putting pacemakers in because they got heart block. Which is going to happen a lot to us. So let's use a group of people that might benefit from pacing, and then let's put some people into the PEA group. And then all these little things, H's and T's are great, but some of them are completely pointless for our situation in cath labs. How many hypothermic patients are going to arrest? How many people is going to arrest from trauma in cath lab, unless you regard what he's doing as trauma? And so they're not useful. But tamponade, that's really important for us. Tension pneumothorax, pacemaker, poking wires into the chest, that's really important. So let's change this to our situation. Coronary thrombosis, we're doing an angiogram. I mean, of course they've got blocked coronaries, so this isn't suitable for our purposes, so we need to change this. We identify the arrest immediately. That poster's designed for people with a bit of a delay to arrest. And we need these specialist interventions. We've got lines in places. And the other thing is, these are just designed to try and get maybe an 8 to 15% chance of survival. We should plan 50, 70, 100% survival, especially in elective patients that suddenly there's a complication. We should be saving these people. And if we don't save them, it's a problem with our organisation, not the fact they definitely wouldn't have survived that perforation of the LAD or that annulus problem after a TAVI.
So I'll just talk you very briefly through the different protocol that we're going to follow in a cath lab. Firstly, everybody's going to wear lead. Secondly, we're going to identify the cardiac arrest, but we're not going to start massage. We're going to split it into 3 different rhythms, not 2. For VF, we're going to immediately do 3 stacked shocks, and then if that doesn't work, we're going to do CPR for 2 minutes. And we're not going to do massage before the shocks. If it's asystole, we're going to immediately connect external pacing and try and pace at 100 beats per minute maximum amplitude. If that doesn't work, we'll then go for 2 minutes of CPR. And then PEA, that as a third part of the arm, will just go straight to massage. We're then going to go round in cycles, but we're going to specifically get an echocardiogram in the room and get an echo on every patient. We're going to give the adrenaline after the second cycle, and after the third we're going to give amiodarone and then start the Lucas device. We're also going to change the important things in 3 categories below. So we're not going to call the arrest team until an established arrest. We're then going to go through specific H's and T's relevant to the cath labs. So hypovolemia, which is bleeding, might specifically be a hemothorax, a retroperitoneal hematoma, pericardial collection, or even an aortic dissection. We're going to look for that. We're going to have an A's, B's, C protocol. We're going to look at special circumstances, allowing the cardiologist to have 1 minute to pause the massage so he can do some PCI. And then we're going to think about things like balloon pumps and when to do angiograms. So it's all quite different. So rather than talking in more detail about this poster, I'll give you an example of one of our practice arrests. Also of note, we always insist on a communication board being filled in before every case, which has got a range of information that's going to help any team in any emergency.
So Liv's going to tell us all about the case we've got today.
We have an urgent patient called Trevor Graham who is about to be brought into the Cath lab after a call from an ambulance crew requesting primary PCR. The paramedics have told you that the patient is a male, 55, current smoker, who called for an emergency ambulance after suffering central crushing chest pain for 30 minutes. We don't have any other information at this stage.
And Madhav, you're my boss. It's a pleasure to be here.
Thanks
and
for coming.
you better crack on. I'm really looking forward to watching this case. I mean, I hear you're an amazing interventionist. I hear you were acquitted in that court case as well.
That's right.
So it's really nice.
Okay, here's another sheet for you.
Yeah, it's really good, isn't it?
Sheet gone in. Now the guide, please. Joel, we've got a locked LED. Need to open that up.
See that?
Joel, we've got a VF.
This is a VF arrest. So I'll tell you what, I'll take charge. We need some people here. Could you go and do the defibrillator? Could you do airway and breathing for me? Could you do CPR on the other side when we say, not yet? Could you stand by the drugs? And could you do resources? You'll need to phone some people. So this is VF. Can you connect up the defibrillator? As soon as you connect it up, we want 3 shocks. So Madhav, do you think this is from an occlusion? You can get that open?
Yeah, I want you to shock him out of it and then tell me when I can start again.
Okay, well, as soon as possible we want a shock. 3 shocks, max the joules as well, turn it on, and you give 100% oxygen, 100% oxygen now? Okay, great. So max the charge up. Yeah. Make sure everyone stands clear, you tell them. Yeah, you just push it.
Everybody stand clear, we're going to do a shock.
Hopefully this will work. So, I didn't do it. Do it again. Charge up. We're going to give 3 shocks. And if it doesn't work, we're going to need to do some massage. So, you're on air and breathing. Yeah.
Still in the I'm going to shock, stand clear.
Yeah. Yeah. That doesn't work. We'll have a 3rd shock. If this doesn't work, you're going to have to start some CPR there. Are you happy with that? Yeah. Okay.
Still in the
And resource person, could you just phone an anaesthetist and phone CCU?
Start CPR.
That failed, right, start CPR. You're going at 30 to 2, please. And also, could you listen to airway and breathing as well? Could you do timing for us as well? We need to time 2 minutes. Yeah. If you could help with the airway and breathing, that'd be fantastic. What is the story? Now, so on the check, the communication board will tell us everything. It's a PCR included LAD. So Madhav, do you think you could open that? Do you want some time to open that?
I need some time.
Okay, team, he needs a minute for this, so we're going to do 1 minute massage, then we're going to give him a minute. Okay? So, okay, thanks. You tell us it's a minute?
Yeah, it's 4 seconds to the minute. And it's 1
Okay,
minute.
stop CPR then, Madhav, you've got 1 minute. Could you tell us at 30 seconds? And then it's a minute.
I'm intubating now. I got the airway in, come out.
And resources, maybe you could find another cardiologist. I think Madhav might need some help. Even though he's brilliant. Yeah, you just keep trying. We'll give you a minute, and then after a minute we'll try and shock. If that doesn't work, we're going to need to do another minute of CPR. So we're now at 2 minutes, so let's have our 2nd cycle of shocks. It's just a single shock. And we're going to massage if this doesn't work. Have we got our massage person?
Charge.
Hopefully this will work.
Stand clear.
Yeah.
Shocked.
Okay, that didn't work. Let's have 1 minute of CPR. So you're on defib, could he be on massage? Yeah. So we're going to do a minute of this. Madhav, do you still think you might be able to get this open?
I think I can get it open, but I just want you to give a good
So could you
CPR.
time a minute and then we'll have a minute off and give him 1 more go? Because on the 3rd cycle we're going to set up the Lucas resources. Could you bring the Lucas into the room? There might be one over there, I think. And just get it ready in the background here. We're going to have to use that, I think. 3rd cycle we'll give adrenaline and amiodarone. There you go. And 1 minute we'll stop give Maddox 1 more minute to try and get this open.
So internally, Joe, we're going to give 1 kilogram and then any other of 5 kilogram is 450.
So we're at 2.
So, 1 minute up.
Okay, CPR off. You've got 1 minute to try and get this open.
Okay.
Try.
You want to hear now?
Yeah, so it's after 3rd cycle, so we've got 2 cycles.
Sure.
So now we're going to have to think about getting the Lucas going.
Yep.
So, Maddox, would you
John,
join?
we got some flow going, but we still have, so you may want to continue CPR.
So, okay, all right. Let's carry up to the 2-minute mark. We'll try a shot in fact.
Stand back.
Yeah. So we'll straight up CPR until we finish our 3rd cycle. You're up to. You've got another 30 seconds, and then we'll try shocking. If that doesn't work, we're going to have to put the Lucas under. So we're going to need maybe 2 people to roll this patient. Maybe if you get the other side as well. We're going to have to lift the person away from me. We'll get this in from this side perhaps.
Okay.
And then, you come this side. And you come this side. And so after 30 seconds, everyone, the plan is we're going to shock. If that fails, we'll get this in and try the Lucas. Yeah? Okay, let's see if this works. This will be our 3rd cycle starting.
Remember the shock still in rear. Everybody stand clear.
Okay, that's failed. 3rd cycle. Right, lift the patient. We're going to put him on a Lucas.
So everyone, when everyone is ready, right on the tray,
Yep, so you come up,
get ready. So we're going to roll the patient over to the right. Okay, my count, 1, 2, 3, go.
That's great. Let's just make sure all that.
Patient back over here.
Right, over you go. That's great. Okay, great. Activate the Lucas. Okay, let's press the on button, which is your side. It's just a big on button, and it's on a ventilator, so it'll be constant. Yeah, that's great. Right. If you want to do any more intervention to make sure you're opening it, then feel free. And can you time 2 minutes as well, please? So, just as you said, we should just make sure we're thinking about which is a T's in case we've got this wrong, but you're not hypoxic.
Anyone got the echo in?
Yeah, it would be a good resource person. If you could find an echo machine, that'd be great. There should be one around. We'd just better check there isn't a tamponade.
So Joel, the everything's opened up, flow's good. It's a matter of getting the room back now.
Alright, okay, right. Well, we don't think he's hypothermic. Hypoxia you've addressed. Electrolytes, we need a blood gas. If you can send the blood gas off. Perhaps a drugs person, you can draw a gas. You've listened to the lungs, so tension pneumothorax isn't an issue. Thromboembolism, we think it's just due to the coronary thrombosis. And we're going to just exclude for a tamponade with the echo. Okay, so could you pause the thumper for us? And can we try a shot? And can you charge up for a shot?
Charging, okay.
One shot.
Okay, still in rear, shocking, everybody stand clear.
Oh, we look wow. Good. Everybody, we've saved a life. Round of applause. Well done.
So I hope you found this interesting. We created a full course that started with these lectures, talks about communication boards, lots of practicals, but also we spent half the course talking about how to avoid arrests in the cath lab and also about emergencies after cath labs. Also we did some practicals, as you saw, on the Lucas, on balloon pumps, on extracorporeal circulation, and a lot of other things. We also set up a whole load of e-learning as well, which is actually accessible right now at calzelearning.com. But the most important thing is this is brand new. We really want to set this up all over the world, and we really want your help. We want to know what you think. We want to make the protocol absolutely perfect, and we want lots of people to give it a go in their units. So if you're interested, get in contact. My name's Joel Dunning at doctors.org.uk, or find us on the internet. Let's all work together to create a new brilliant protocol that will save lives in cath labs and after cath labs, and help people deal with their most important emergencies.